A very warm welcome and thank you to everyone for joining us today for the launch of our Lung Cancer Europe's fifth report, which is on the psychological and social impact of lung cancer. I would also like to thank the ERS and ELF for their endorsement of our event. 2020 really has been a year like no other. Our lung cancer communities have faced and are still facing significant challenges, all in the midst of a global pandemic, which has severely affected healthcare services and delivery. The risk of getting lung cancer has not paused because we find ourselves in these such surreal times. So we would urge you, if you have any issues or you feel that something is not quite right, please do go and get checked out. As you are aware, November is Lung Cancer Awareness Month, and as part of our activities at Lung Cancer Europe, we always launch our annual report at this time. Usually we find ourselves at the EU Parliament in Brussels. However, as I said before, things have changed so much this year and everything has gone in a virtual world. And we are delighted to now launch our report virtually with you all today. Before we get started, I just have a couple of very quick virtual housekeeping notes. This meeting is being held on Zoom by invitation only and streamed online on Facebook and YouTube for the general public. Those of you who have joined us by Zoom, please be aware that your microphone and your camera will be disabled throughout the meeting. We hope we can keep to time and will hopefully have space to ask questions later in this meeting. And for those of you who have joined by Zoom, please use the chat function to ask your questions. For those who are joining us via streaming on YouTube or Facebook, please type your questions in the comment box. I would also like to remind everybody that this meeting is being recorded and it will be uploaded onto our YouTube channel after this meeting is ended. The report and all of the related content associated with our report this year will be released at 1:30 Central European Time once this event is over. So I will just move on to give you a brief overview of our agenda for today. So my name's Anne-Marie Baird. I am the president of Lung Cancer Europe, having been elected in May of this year. I'm just going to start by giving you a very, very brief overview of Lung Cancer Europe. We're then very pleased to welcome Sean Kelly, member of the European Parliament, who will give an EU perspective. This will then be followed by myself presenting some findings from our report. And then we will have a talk from Degsi Kaseba, who will talk on the psychological and social needs of people impacted by lung cancer. This will be followed by short videos from patients and caregivers giving their perspective, Deborah, Meryl, and Gunter. This will be followed by a Q&A moderated by a fellow board member, Lavinia McGee, and then we will have our call to action given by Tommy Bjork, board member of Lucha, and then our closing remarks. So Lucha is a non-profit European umbrella organization, and we're working and advocating to improve diagnostics, care, treatment, anything really that anyone impacted by lung cancer needs across the care pathway. Our purpose is to be the voice of people affected by Lung Cancer Europe and advocate a network to improve outcomes for the entire community. Our vision is to be an equal stakeholder in the community so that no one dies from lung cancer anymore. Everything in Lucha that we do forms around our pillars, our values, and our objectives. So all of our education, awareness, and advocacy, these are the three pillars we base everything on. Our objectives as an organization and with our members are to help to destigmatize lung cancer because we know this is a huge issue in the disease, help to improve early diagnosis, increase equality of access to innovative medicines and clinical trials, build capacity amongst our members across Europe, and provide a space to educate, empower, and network all of our members together wherever they are across the EU. Our values are based around our commitment, reliability, trust, uniqueness, and representativeness. And we hope that we can invite all of you to join us as we work towards improving outcomes for the lung cancer community. Currently, this is a snapshot of our Lucha members network. We have 14 full members and 17 associate and individual members, and these are representing 21 countries across Europe. We have a number of other organizations and individual members currently undergoing the process for membership to join our community, and we hope that we will see our numbers continue to increase next year and following years. And of course, if you are interested in joining Lucha, please do get in touch with us. So it is now my great pleasure to introduce Sean Kelly. Sean is a teacher by profession who was elected to the EU Parliament in June 2009 for Ireland South and is a member of the EPP group. Sean is also a member of the newly formed MEP Lung Health Group at the European Parliament, and this is a group of MEPs interested in exploring the legislative and non-legislative measures that can be taken at a European level to promote lung health and tackle respiratory disease. So thank you so much, Sean, for joining us today, and we look forward to hearing the EU perspective from you.
Thank you very much, Anne-Marie, and let me begin by thanking yourself and also Trinity University in Dublin and Lung Cancer Europe for allowing me to host such a pivotal event. I would also like to welcome you and your respected panelists to today's virtual launch of the Lung Cancer Europe's report on psychological and social impact of lung cancer. We are, as you said, in the midst now of another type of health crisis, demonstrated by the fact that we are having this discussion from the comfort of our homes or workplaces, a testament to the vast change we will have experienced over the last few months. Although I must say personally, I would much prefer to be hosting it in Brussels because you can't beat the personal interaction. However, let's proceed. Lung cancer is one of the most complex of all common cancers. The disease is multifaceted and continues to be the biggest cancer killer in Europe, causing more deaths each year than colon, breast, and prostate cancers combined. Lung cancer is such a huge killer, partly because it is harder to detect in its early stages. By the time a person begins to notice the symptoms, it is often spread to other parts of the body. Unnecessary deaths of lung cancer sufferers could be avoided if there was greater access to innovative treatment and more efficient organisation of research. Improvements depend primarily on greater collaboration between member states and across the healthcare sector. The collaboration should include patients, caregivers, and patient organisations who have an incredibly important contribution to make. Prevention and early detection are key to reduce the burden of lung cancer in Europe. As policymakers, we need to support policies that broaden cancer screening programs, commit to reducing exposure to risk factors for cancer, and support further research related to lung cancer. I think all this is doable. The fight against lung cancer is lagging behind other cancers in some respects. One reason is a general lack of funding for research, but another reason is a relative lack of patient advocacy, as so many patients, unfortunately, lose the battle with the disease. From a personal point of view, I find this heartbreaking. This, of course, carries a heavy psychological and social burden, not only for people with the disease, but also for those in a caregiving capacity. Caregivers, be they family members or friends, provide constant physical, practical, and emotional support. We have many, many wonderful people in Ireland, like many countries in Europe, who have dedicated a big part of their lives to going above and beyond in caring for their loved ones. These carers are exceptional people, often hidden heroes. They give their energy, time, and love to others every day in order to ensure comfort and quality of life for their family at home. I, along with my party colleagues in the European Parliament, was proud to nominate Family Carers Ireland for the European Citizens Prize 2020 in recognition for such work, and I am very confident that they will receive the prize, most deserved. The extremely quick development of a COVID-19 vaccine is a high-profile success for European research and innovation policy, and indeed European funding. It shows once again that research saves lives, and we must continue to invest in order to lessen the impact of lung cancer. Member states and the EU institutions should act together to overcome the barriers to innovation, including recognizing the value of new testaments and making access to them easier, boosting research across Europe and including all stakeholders, and particularly patients, in policy formation. The health of our citizens hits at the very heart of the EU. The pandemic may have some benefits in this regard, in terms of awareness of preventative measures, appreciation for healthcare workers and researchers, as well as an increased knowledge of local, regional, and national hospital capacities. We need to translate this increased awareness into increased engagement of government and society as a whole, lung cancer especially. More effort is still needed in prevention at EU and national level with public awareness. I was surprised to learn that women who on average do not smoke in the same numbers as men account for nearly half of the new cases. This makes lung cancer an increasingly special concern for women. More awareness of the disease and the risk factors should be developed, particularly among younger people, women, and even doctors. Europe needs to find ways to detect this disease before it is too late to effectively treat the patient. And this will only be achieved through more research. Addressing the risk factors is the EU's first line of attack for reducing the burden of cancer. Actions include legislation on pesticides, air quality, and exposure to carcinogens at work. The ambitious EU tobacco control policy includes robust laws regulating tobacco products and banning advertising and sponsorship, and awareness-raising campaigns. Strategies and platforms for joint action on alcohol and nutrition and physical activity bring together EU countries and stakeholders, including NGOs and industry, to tackle these risk factors. During the past 7 years, the EU has invested nearly 1.5 billion in international collaborative research, frontier research, mobility programs, public-private partnerships, and coordination of national cancer research efforts. Over half of this budget, 770 million, is used for collaborative research projects to find new ways to fight cancer and help patients. There is still room to do more. The EU needs to introduce guidelines on lung cancer screening to support member states to implement screening programs for high-risk individuals. We, of course, need to continue and even increase research and innovation in medical sciences in order to continue to broaden our understanding of the origins of cancer and to support the development of effective prevention and treatment methods. In the European Parliament, as you said, Anne-Marie, there is a special committee on beating cancer that aims to strengthen the approach at every key stage of the disease: prevention, diagnosis, treatment, life as a cancer survivor, and palliative care, ensuring a close link with the research mission on cancer in the future Horizon Europe research programme. The EU is making cancer one of the core mission areas of Horizon Europe and putting cancer research high on the agenda of the upcoming Europe's Beating Cancer Plan will help to address the disparities across member states. The EU targets for 2030, that is, more than 3 million lives saved, living longer and better, prevent what is preventable, optimize diagnosis and treatment, support the quality of life of all people exposed to cancer, and ensure equitable access to the above all across Europe. What is not recognised as widely enough is the emotional and social effects of cancer, be that the diagnosis, treatment, or seeing the whole difficult process happen to a family member or loved one. Sometimes people find it difficult to express how they feel, leading to consequences for mental health, and I saw your research was very clear on those aspects. It is therefore very important that we make available the necessary support systems such as oncology, social workers, counsellors, or support groups who can help affected individuals develop more effective ways of coping and talking about cancer. However, for our actions to be successful in this regard, we need to reduce the stigma associated with lung cancer and really inject more compassion for lung cancer patients and their loved ones into public and community discourse. Cancer patients also face social challenges as well as emotional, such as the loss of work capacity, rehabilitation time, and potentially, unfortunately, disability, which all require a comprehensive approach close to a patient's living and working environment. There needs to be structured development of pathways that encompass the transfer of cancer aftercare into community care settings, along with adequate training of all health and social care professionals involved in the process. Quality of care brings a quality of life. I am sure these topics will be well covered in our seminar here now, and I will be very interested to hear the interventions of the illustrious panel which you have. To conclude, I would like to thank everyone for joining us here today. I would also like to thank Lung Cancer Europe for the opportunity to host this virtual launch and speak about such an important topic. And hopefully, the next time we have an event, we'll be able to do so in person once again from the European Parliament in Brussels. Enjoy the discussions ahead, and it's a great honour to be with you. Go to Thank you.
Thank you so much, Sean, and thank you so much for giving such a broad overview of the EU perspective there. And I would just like to second your call out for greater research, greater funding into this area. And you make such an important point that we really all have to come together as a community to work more for people impacted by lung cancer. And you also make such a really stark and important point as well about having that patient voice there, because we really need to ensure the patient voice is in everything that is done for the community, not just in lung cancer, but for other cancers as well. And really, patient-centred care begins with patient-centred policies. And this is something that the EU should do as they're moving forward with all of the different cancer action plans that are ongoing there at the moment. So thank you so much again, Sean, for that great overview. And it was great to hear all of those different things that are going on at the EU level. So with that, it is now my job to give you an overview of our report findings. I have to say this is going to be no mean feat because our report this year is extensive and it's probably one of the most complex reports we've ever done at Lung Cancer Europe. So I have tried my best to pick out certain items from the report to share with all of you today. However, as I said, after this event is over, our full report and all of the associated materials will be available for download from the Lung Cancer Europe website. So thank you, Alfonso. Alfonso is in mission control and is assisting with all of these things today. So thank you so much, Alfonso. So why did we decide to do a report on this? Well, we felt that the psychological and social impact with lung cancer is something that we do have some research on. We have a lot of anecdotal kind of evidence, and what we really wanted to do was to try and generate more evidence in this area across Europe. Of course, we know that patient-centered care is about focusing on the needs of the person, but sometimes people need to be reminded of that. Focusing on the needs of the person requires an understanding of their experience and identifying their needs and their priorities. As Sean has also alluded to, people in a caregiving capacity, families, loved ones, friends, whoever it may be, are also impacted when there's a diagnosis of cancer. And we also need to work on identifying their needs and their priorities as well, as this has to be something where we're able to provide supports to the entire family and not just one person. So the purposes of our report this year is really about raising awareness of the emotional and social issues related to this disease as reported by those impacted by lung cancer. So the aims were to obtain a better understanding of the psychological and social, otherwise known as psychosocial, impact of this disease under a number of different spheres such as emotional well-being, daily life, family and loved ones, and work and finances. We wanted to explore the experiences in relation to patient care and support. This was in terms of healthcare professionals, families and loved ones, patient organizations, and non-profit associations. We wanted to identify areas which must be improved upon in order to enhance psychosocial supports, because we know this is an area of high unmet need for our community. So the methodology for our report is similar to other years. There was an extensive literature review undertaken, which helped craft our surveys and interview questions and sort of the introduction and a lot of other things in our report, as you'll read through it when you see it. We had 10 qualitative interviews with different experts in the field. And then we constructed an online questionnaire with about 40 questions in it. And this was translated in 12 European languages, because again, we know that language is a huge barrier across Europe. We had 559 responses to our online questionnaire. A little breakdown of that number. So those with lung cancer who responded to our survey was 365. Those in a caregiving capacity was 194. And this is really the first time Lung Cancer Europe has really gone out and specifically sought input from those in a caregiving capacity. There was 17 countries represented in our responses. So this varied from quite a large number in some countries to smaller numbers in others. France, Spain, Denmark and Italy were amongst those most represented. The majority of our respondents in both categories were female. The primary diagnosis was adenocarcinoma, which is a type of non-small cell lung cancer. The majority had stage 4 disease and were diagnosed between 1 and 3 years ago. And the illness, the disease, was still present despite treatment. So when we look at the impact of lung cancer, one of the questions that was asked was, to what degree has each of the following been negatively affected because of lung cancer? So here in this graph, you can see it both in terms of patients and caregivers. And really the biggest thing to come out of this was emotional well-being. Huge negative impacts on emotional well-being and the family in and of itself. Future expectations also ranked highly, and worries about independence was also a concern. When we look at the psychological impact in terms of feelings and emotions because of a lung cancer diagnosis, you can see that there was quite a broad number of different feelings and emotions, and people don't necessarily feel these all at one time. They don't necessarily feel them only at one part of the care pathway. These are emotions and feelings that can happen to anyone at any time. And those that really came out was the uncertainty that people face when faced with a lung cancer diagnosis, the sadness that comes with a cancer diagnosis, the anxiety, the fear. And these are all things that are very impactful on how someone's dealing in terms of their psychological well-being, as well as everything else. We did see other things that came out: anger, frustration, vulnerability, hopelessness, loneliness, reduced self-esteem, and feelings of guilt about their cancer diagnosis. And we also found that a number of people who responded to this survey felt feelings of shame. And I think some of these things are linked back to the stigma that people associated with this disease. And it is really, really something we need to work harder on as a community and reduce the stigma associated with lung cancer. When we look at other psychological impacts, and again, please remember, this is a small snapshot of what is in the report. We also looked at things in terms of depression. So did people feel maybe depressive? Did they have anxieties? Did they have worries? Did they feel that they were capable of enjoying things? And what we found was around 1 out of 4 caregivers reported an inability to enjoy anything during the previous week. We also found significant numbers of both caregivers and patients had worrying thoughts and had these worrying thoughts very frequently. We also found that a large number of caregivers and patients had issues in feeling relaxed. And we also found that a lot of people felt very slowed down. And one of the other interesting things to come out of this is a number lost interest in sort of their appearance and different things that they associated with themselves. So really what we found here is that depression is an issue for our community. When we look at other psychological impacts, and the next 2 slides are going to be around stigma, because this came out as something that was frequently talked about in other literature and things that we looked at. From a patient's experience, we can see that a lot of things were experienced by patients a little bit of the time, or somewhat, or quite a bit, very much. And one of those things that stands out is when people learned about a lung cancer diagnosis, half of those that responded to the survey were asked if they had smoked. This question around smoking is something that seems to be an instant reaction people have when they find out that someone has lung cancer. The only time questions around smoking should be asked is really between a patient and their doctor when they're deciding of diagnostic workup and treatment. For any of us, what we need to be there for is for support and help. And really, it is none of our business what a smoking history is of anyone. We know that by asking these questions, we're reinforcing blame, stigma, and we're really perpetuating that cycle, and it's having a huge negative impact. We also found that there was about 20% considered the people responsible for getting lung cancer, for judging people negatively for having lung cancer, and for treating people poorly because of lung cancer. I think if we looked at any other common cancer type, we wouldn't be seeing these type of figures. When we looked at, again, this is in terms of stigma and the patient's experience since their diagnosis, we can see that a lot of people felt they had to be careful about who they've told about their lung cancer diagnosis. And we know anecdotally that some people who are impacted by lung cancer do not want to tell anyone that it's lung cancer that they have. They may instead say that they have breast or prostate, because we know that they feel that this is sort of more accepted, or there's probably more of an empathetic response compared to if you say you have lung cancer. So 35% of our respondents is quite a sizable chunk of people. About 40% of those that responded had stopped spending time with some people. About a quarter of people felt that they needed to keep their lung cancer diagnosis a secret. And about 20% regretted telling certain people about their lung cancer diagnosis. These are really very, very stark figures. And all of these things contribute to the psychological harm and impact that comes from a lung cancer diagnosis. When we looked at impact on daily life, and again, this is just some snapshots from the report, we know that a lot of people, not just impacted by lung cancer, but by other cancers, have an issue with financial toxicity. And in our survey, we found that a lung cancer diagnosis did impact the household financial situation in terms of less income, costs associated with medical appointments, drugs and treatment. Some may have had to go to private healthcare services for support. And something that should never be overlooked is the parking expenses to go to medical appointments. I mean, we know that the costs associated with parking can have an influence on people signing up for things like clinical trials or attending other services or care that might help them. So we have to sort of go back to basics a little bit and realize that all of these things add up and add to the financial toxicity faced by people impacted by cancer. When we look at why some of those reasons for those financial differences in their household financial situation, really it was all around an inability to work for over half the respondents of this survey. Others had to take time off work. Early retirement was an option that some people had to take. Those that were self-employed or had their own businesses may have had to leave or close the business. There was also a lot of concern about maintaining their job. There might have had to be a reduction in hours because of, going to medical appointments, dealing with side effects of treatment, the impact on quality of life, all of those different types of things. And it is, important to note that 6% faced dismissal from work. When we look at impact on daily life in terms of family, we looked at the main emotional and social difficulties that was observed within their family. And on this chart here, we see it both for patients and caregivers as indicated by the different colours. So really the high emotional impact on one or more family members was a huge thing for those that responded. The physical tiredness and fatigue associated with this disease is also a huge issue. There is, of course, sometimes overprotective attitudes, which can annoy people. You feel that in and of itself is a barrier to you maintaining your daily life, getting back to normal. There was also a lot of people, particularly in caregivers, where they found that there was a distance in relationships with their social environments. There's also issues around perceived changes in behavior, distancing themselves from different things, irritableness, impulsiveness, lack of concentration, overloading of responsibilities, abandonment of work, studies, hobbies, and again, changes in physical appearance. So all of these things to differing amounts were impacts for both patients and for caregivers. When we looked at supportive care needs, we asked what did they feel were their most prevalent unmet supportive care needs. And again, we have a figure here on our left for both patients and caregivers. And we see that psychological needs is a big thing for both caregivers and patients. Help around symptom control and management, because we know there's side effects and quality of life issues associated with treatments for this disease. Impact on family is a huge thing that continues to come out. Issues around rehabilitation and exercise, whether it's prehab or rehab. Just the daily living needs is also issues. There may not be help or support there. And again, the financial aspects come up, and other things such as nutrition, work, sexual life, and fertility issues. Because as Sean said, we know that more younger females are getting this disease, and something we really have to think more in is around those fertility issues for that specific cohort of people impacted by this disease. When we looked at sort of professionals who they felt might be able to help or support or be needed as part of their pathway, psychologists were a huge unmet need. And really, it's something that we need to do more on and to provide more services within this area. Dietitians and nutritionists were also something that was felt that was needed. Physiotherapists, whether it's helping with pain, breathlessness, fatigue, social workers to try and get through all the different issues that are faced. There might be mountains of paperwork that have to be filled in, whatever it might be. Access to palliative care teams, psychiatrists, and of course lawyers, because some people feel that they really have to kind of get everything in order, and therefore they struggle sometimes in getting maybe the legal help they need to get all of their affairs together. So are these needs being met? Well, a vast majority of those that responded to this survey were saying, particularly in caregivers, no, their needs weren't being met, but they would like support. Or the other main response was, yes, they were being met, but only to some extent. So for very few people are all the supportive care needs being met. When we asked about support from patient organisations or non-governmental organisations, the vast majority of those responded had indicated that they had not received support. Now, there was a lot of different reasons for this, and it was something we didn't go into in a great detail in our report, but we know from other studies it can be down to, in fact, not knowing what services are out there or available. And when we looked on whether or not people can count on anyone to help provide emotional support, we did see that there was a variation for patients and caregivers, but most really felt that they still did not have someone to count on for emotional support most of the time. So really, I know this is a quick snapshot of our report, and I know when you read it, there's a lot more in there and it will take some time to digest. But really, the overall finding in this report is that we want to stress the need to implement more friendly, more accessible, and more holistic approaches to healthcare services. And we know that there is specific unmet needs for both patients and caregivers around psychological and social supports. So that ends my brief overview of our report findings. And our next talk that we're going to have is from Saba Deji. It is my pleasure to introduce him now. He is a licensed principal social worker Director at the International Psycho-Oncology Society and Director at the European Cancer Organization, and is an Associated Professor at Babeș-Bolyai, I'm so sorry if I've mispronounced that, in Romania. Now, at the moment, he's under quarantine, as a lot of us have found ourselves in this year. And therefore, he was very anxious about having connection issues to our meeting today. So we're now going to have a pre-recorded talk from him. However, he will be online to answer any queries or questions you may have. So thank you very, very much for being part of our meeting today, Saba.
I am from. Good morning. My name is Csaba Dégy. I am from the International Psycho-Oncology Society. And I am welcoming all of you to the 5th Luce report. Thank you so very much for your kind invitation. This morning, I am speaking to you from Cluj, Romania, and I am going to have a presentation on the psychological and social impact of lung cancer. We are going to start with the patientship. Of course, this is a word that I invented, but it certainly reflects the multidimensional burden of lung cancer on people affected by it, with all the difficulty of care. We are going to start with the psychosocial challenges in lung cancer. Patients with lung cancer are a neglected population in the area of psychosocial needs recognition and psychosocial care. They uniquely report among the highest added burden from stigmatization and are particularly likely to experience increased cancer distress. Stigmatization and smoking-specific concerns are of high importance because they are related to delayed treatment or maybe denied treatment, reluctance to disclose cancer status, and difficulties in asking for help, for example, in attending support groups. The negative psychosocial and behavioral implications of the health-related stigma are far-reaching for smokers compared to non-smokers. Patients with lung cancer are highly distressed before, during, and after cancer treatment. The overall prevalence rate of distress for lung cancer was found to be higher than 40%, and more than half of this population is interested in one or more psychological services. Actually, it was found that oncologists failed to identify distress in 68% of patients with lung cancer. Actually, non-disclosure, as we are going to see it, of the lung cancer diagnosis could be linked to the severity of distress in this clinical context. Depressive coping, emotional distress, and anxiety were all associated with shorter survival, respectively increased lung cancer-specific mortality, even after controlling for demographic, biomedical, and treatment variables. Diagnosed with lung cancer is one of the variables which is in the cancer diagnosis non-disclosure profile, together with being older, 55 years or above, with a mandatory or vocational education, living in rural communities, not receiving chemotherapy, male gender, advanced stages of the disease, and lack of cancer experience in the family. Speaking about family experience in lung cancer, it's very important to not blame the game. Actually, lung cancer patients' family caregivers reported up to 50% of clinically elevated distress, and more than 33% reported negative physical health as effects of caregiving. Lung cancer may be particularly distressing for family caregivers because of its high physical symptom burden, sometimes more the time, poor prognosis and stigma, particularly when the patient persists in tobacco use. The family environment of blaming the patient during times of illness can affect both patient and caregiver depression alike. Blame or anger toward lung cancer patients may alter help behaviors or help-seeking behaviors and reduce communication between primary caregivers and patients. And it's not easy for family members because they're trying to coordinate everything. The majority, 74% of distressed family caregivers of lung cancer patients experienced one or more adverse economic or social changes since the patient's illness. And these hardships appeared even though most caregivers were from middle to upper class and most of them had health insurance coverage. Loss of the main source of family income and disengagement from most social and leisure activities predicted greater caregiver distress. The majority of the total economic burden experienced by informal caregivers of lung cancer patients, specifically 91%, arose from the direct effort of providing informal care to patients. So it's extremely timely and important to talk about caregivership. We are going to see caregiver skills, resources, and interventions. According to a white paper published by the European Cancer Patient Coalition and Eurocarers, carers already provide 80% of care in Europe, of cancer care. While people with cancer are often identified through their diagnosis, medical status, cancer carers often remain largely anonymous, despite their fundamental role that they play in the healthcare pathways. Only a total of 39% of cancer carers interviewed describe themselves as carers. And this is a very important thing because as we are looking to the physical side of caregivership, we see that cancer caregiving is related to increased blood pressure, dysregulation of the autonomic nervous system, and dysregulation of the stress axis of the hypothalamic pituitary axis, immune changes, and poor health-related behaviors, as you can see in this proposed model of the impact. Also, according to the Macmillan from United Kingdom, 70% of carers, cancer carers, experience some form of emotional impact from caring. Almost 40% of spouse caregivers reported depressive symptoms in a range that is likely to be clinically significant, and this is a prevalence that is almost twofold that of their ill partners. And the marital dissatisfaction was found to be even more important contributor to depression than the objective caregiving burden. So it's very important to do this kind of dyadic investigations. And as you can see from the work of Professor Kim Young-mi from United States, for both patients and caregivers, poor mental health at the diagnosis posed significant risk to their physical health. Distressed patients showed stagnated physical health recovery, and distressed caregivers showed accelerated physical health decline. Caregivers' physical health declined mostly among those reporting low mental health at diagnosis and whose patients reported low physical health at diagnosis. Also, depressive symptoms predict cancer caregivers' physical health decline. This study, published by the same research group, actually provided novel information regarding cancer caregivers' long-term physical health decline. Only caregivers' higher depressive symptoms, so only this, predicted their accelerated physical health decline from 2 to 8 years following the cancer patient's diagnosis. Here you can see depressive symptoms and quality of life 5 and 8 years post-diagnosis among cancer caregivers. On the left, you are going to see that depression is a long-term challenge for this population. The first evidence that 5 years after the initial cancer diagnosis in the family, shows that many family members who remain in an active caregiver role or those who have become bereaved suffer from depressive symptoms, serious enough for concern. These findings, of course, highlight the importance of caregiving stress and social support early in caregivership. On the right, you're going to see the results from the 8 years post-diagnosis. This is the first evidence that family members who became bereaved by 8 years after the initial cancer diagnosis in the family suffer from poorer mental health and greater psychological distress years after the loss. Bereaved or currently caregiving family members at the 8-year mark reported poorer mental health and greater distress than family members of survivors who were in remission. So this is a highly important topic which, imposes actually to talk about requirements, essential requirements for quality cancer care in lung cancer, which is sometimes problematic, stigma sensitive, and hidden most of the time. As essential requirements for patients, we believe that distress and quality of life concerns of patients with lung cancer should be addressed, monitored, and treated promptly and as clinically indicated throughout the disease trajectory. The empirically validated distress thermometer is acceptable for rapid distress screening in the oncology context, as it opens up communication on psychosocial burdens and significantly reduces time to referral. Failure to detect cancer distress, as we have talked about in the introduction, as well as increase the levels of distress in lung cancer patients, might serve as barriers to treatment, decreasing patients' health-related quality of life, increasing health care costs, and negatively impacting smoking cessation efforts. As essential requirements for caregivers, we think that policymakers must formally recognize the role of carers and provide appropriate welfare programs, including paid carer leave, flexible work arrangements, financial compensation, and pension rights. Carers must have access to programs, including information, training, and psychosocial support, and must be included in the patient's care team. Carers must be encouraged to identify themselves as carers and take part in support programs, given that many do not identify with the term, as we have seen from the ECPC report. At European level, governments must adopt the New Start initiative for work and life balance for parents and carers proposed by the European Commission. Of course, psychosocial interventions are beneficial. Overall, 65 of the studies led to positive and significant improvements in functioning for informal caregivers and patients for whom they provided care. And it's extremely important to highlight that couple-based interventions have similar effect sizes, are as beneficial as are the patient-only or caregiver-only interventions. The increased use of smartphones, telephones, and alternative modalities nowadays during COVID-19, like Skype, Zoom, for intervention delivery is likely one solution or one of the solutions to the barriers of delivery. Web-based interventions actually may reduce negative mood in caregivers of patients with cancer. Web-based caregiver and patient intervention are as effective as traditional interventions, although at this point, quality of current web-based caregiver interventions is weak in lung cancer. I would like to kindly thank you for your attention, and invite all of you to our next meeting at ECHO, a roundtable meeting on lung cancer on 7th of December, when we are going also to launch the new paper on ECHO essential requirements in quality cancer care for lung cancer patients. Thank you so very much, and I am looking forward to the Q&A session.
That was great. Thank you so much for that absolutely fantastic talk. And we do look forward to the launch of those essential requirements for quality cancer care for lung cancer from the European Cancer Organization on December 7th. I was very privileged to be part of that team and that publication. And I know it's going to be great to have that. And these are going to be essential requirements that anyone impacted by this disease should be able to access, whether it's services, professionals, whatever it might be. So we really, really look forward to that. And thanks for such a great talk. So next up on our agenda is really the most important part of our entire meeting. This is patients and caregiver perspectives of the psychological and social impact of lung cancer. And I would just like to say a truly heartfelt thanks to Deborah, Meryl, and Gunther for sharing their experiences with us today. And these are pre-recorded in a video as well. So Alfonso, if you could start that now for us, please.
My name is Merel Henning. I'm a mother of 2 teenagers, wife, historian, and lung cancer patient. In November 2014, I was diagnosed with non-small cell lung cancer at the age of 46. Thanks to proper diagnosis and access to innovative treatment, I'm still alive 6 years after being diagnosed. I have the ROS1 fusion, which can be treated with targeted therapies. And I'm lucky to live in the Netherlands with a great healthcare system. Being diagnosed with a terminal cancer is absolutely devastating. Suddenly, you don't have a future anymore. A great philosopher and cancer patient in the Netherlands used a metaphor. When you are healthy, you're sitting in a speedboat, looking at the horizon at a great speed. But when you get a deadly disease, you have to switch boats, from a speedboat into a rowing boat, living in the present with no future to look out for. Right after my diagnosis, people said to me to live life now, to enjoy now. I couldn't do that. I was still mourning my death sentence. People all give well-meant advice. Be happy, eat no sugar, enjoy. But I was not okay. I learned that it was okay to be not okay. Only recently, doctors call a little attention to the psychological needs. Due to research developments, some patients live longer and have different needs, but we all have to ask for that. Having a deadly disease was for my family even so hard, if not harder. My children were 8 and 10 at that time, so they understood the impact of dying. Luckily, we were seeking help immediately, so we could discuss with a psychologist how to bring the message. They went to a grief counselor to get the chance to mourn by life. But a lot of patients do not know what to do. They do not know what the possibilities are, so they lack the right treatment and the right care. But also the financial and social consequences have a huge impact. With the loss of a job, you lose a part of your identity. You have to renew yourself. Suddenly, you are of no value to the society anymore. You sit at home in a rowing boat while your surroundings stayed at the same speedboat. With a loss of work come the financial struggles and so stress. You can't get a mortgage anymore. You can't get a loan, an insurance, And what is the risk to buy a new phone every 2 years? Am I alive after 2 years? In the Netherlands, I'm lucky with the social safety net. I have my inability insurance with the struggle, but the struggles remain. Some very good friends couldn't handle my disease. They found it difficult to talk to me, and sometimes conversations were a bit awkward. I lost some good friends. They thought that the cancer divided me. A new social structure had to be built. Nobody can really understand the anxiety, the constant fear what the scans will reveal, the lack of future treatment options, the prosperity of a horrible deathbed with suffocating shortness of breath, or the certainty to not see your children grow up, not going to be a grandma. Words like balancing, coping, and managing are all verbs. Being sick is like a marathon without a finish line, except death. The only people who can fully understand a patient with lung cancer is another patient with lung cancer. The fears, anxieties, side effects, coping mechanisms are all shared. One sentence is sometimes enough to understand each other. So we have to change. What can be done? Empower the role of patient organizations with a different kind of funding. Empower the role of patient advocates. Make the national code of conduct, for instance, a European one. Think more European. Make cross-border trials, treatments and research possible. We patients, we want hope. Hope of a next treatment option, hope of a good quality of life, hope of a life. Thank you.
Hi, I'm Günter Kranz. I live in Berlin with my wife Susan. We have been married for 47 years. I would like to tell you about my wife's life with lung cancer. In autumn 2006, my wife and I bought a sauna. As we sat sweating in it for the first time, my wife noticed a knot in her breast. The diagnosis of breast cancer was confirmed in December, and the first of 2 operations took place in January 2007. During the preparation for the second surgery, the lungs were x-rayed and the doctors spotted a suspicious shadow on the left side. Shortly thereafter, my wife received her second cancer diagnosis within 4 weeks: lung cancer. It was an autonomous tumor that had no connection to the breast tumor. My wife had 2 operations on the left lung in 2007 and 2008. During the chemotherapy after the second operation, metastases were found and treated with a new targeted therapy. A shot in the dark, because there was no tumor testing at that time. The metastasis disappeared because the drug worked, and it still does. 1 year after the second operation on the lungs, in April 2009, my wife and I started an 800-kilometer hike along the Spanish pilgrims route to Santiago de Compostela. It took us 5 weeks to reach our destination. This experience has changed the priorities in our lives. It enabled my wife and myself to come to terms with their lung cancer. Since that time, my wife has had no fear of the results of checkups. After our hike in Spain in 2010, 2 new metastases were found in my wife's lung. The old and the new tissue samples were compared, and the doctors confirmed that a mutation had occurred. The metastases were successfully medicated with a special radiation treatment, and my wife has been tumor-free 8 years. My wife is a cancer survivor because her tumors were discovered early. In our self-help group, we find that early diagnosis, unfortunately, is exception rather than rule. My wife coped very well with her surgeries, radiation and chemotherapy because of her fitness. We were both long-distance runners at the time. However, at all stages of her treatment, neither she or I was offered psychological support. Although my wife tried to be confident at all stages of the treatment, she was worried about how long she would survive and how I and our sons would get along without her. For me personally, the diagnosis of lung cancer had serious consequences. I was terrified for my wife's life. I was breathless and couldn't concentrate for months. I had great difficulty coping with my day-to-day work. With the generosity of my boss, I was able to choose whether to go to work or to take care of my wife. Our two sons and their families were also very concerned and had great problems dealing with the situation. A few years after my wife's second operation on the lungs, we accidentally met a member of the lung cancer self-help organization in Berlin. We started attending the group meetings, and finally, we got the answers to all the questions that had accumulated. In our opinion, the work of patient organizations is extremely important. In the group, in a confidential atmosphere, lung cancer patients receive answers to the questions that often cannot be discussed in the clinical setting. We invite different experts to our group meetings. These are, for example, oncologists, nutritionists, respiratory and sports therapists, specialists in skin care, or wig makers. Reports of group members give newly diagnosed patients courage and hope. My wife is the living example of that. With lung cancer, a good and long life is possible. Many of the newly diagnosed patients experience strength and confidence through my wife's story. As a self-help organization, we accept from the hospitals to strongly improve the psychological support of cancer patients as well as their preparation for life after discharge. To achieve this, however, it is necessary to employ more psycho-oncologists and palliative care physicians and recognize the great importance of their work. Thank you very much.
Hi, my name's Deborah Montague and I am 55 years of age. I was diagnosed with ALK-positive lung cancer 4 years ago. In fact, it was on October the 6th, because you don't forget the date that you're diagnosed. It came out of the blue, I must be honest. I was working full time, fit and healthy. The only issue I had was I had a slight cough that went on for a couple of months. And it was actually work colleagues that made me go to the doctors because I was annoying them so much because of this cough. So I only booked an appointment really then, and then I thought it was maybe adult onset asthma because there was nothing wrong with me. I mean, I was tired, but then I was working 50, 60 hours a week, and I just put it down to that. Anyway, was sent for an X-ray and blood test. They came back nothing, just inconclusive. So sent me off to a respiratory consultant who did the same tests and said the same thing, then decided to do a CT scan. So I went back on the evening of October the 6th. I went, it was quite dark because it was about 6 o'clock, the appointment. And I went on my own because I wasn't expecting anything untoward. So that's when I was told that what they had found was a secondary lung cancer. So they wanted to do another scan the following day to find out where the primary was. And I found myself in the weirdest situation that night, coming home and Googling primary cancers to work out which one I wanted. So if there was the spot in the lung was the secondary, then which did I want? And working out the bone cancer wasn't very good because that really hurt. Stomach cancer wasn't very good because your life expectancy was very short. And literally, and which is a bizarre position to be in. So starting to have my fingers crossed as to which one. And I got to be honest, lung cancer was one of those that I didn't really want when I looked at the stats online. Anyway, lo and behold, it turned out to be lung cancer, and several weeks later I found out that it was ALK. They were really long weeks waiting because by then the cough had developed, and actually I was struggling to breathe and talk in whole sentences by then. So they were three long weeks waiting for those tests, not knowing what was going to happen, being told that if the tests came back well, then I could have up to 2 years, but if they didn't come back in the same way, then it might be as little as 6 months. So yes, there wasn't a whole lot to look forward to at that stage. I think one of the most overriding feelings I had was of guilt, because obviously I upset all my family. They were devastated when I told them, and you feel so guilty that you've upset them so much, and it's down to you, and there's nothing you can do about it to make them feel better. So that was really hard, very, very hard. And also, you just want to be the same as your friends, so you want to pretend it's not there, and to try and do what they can do, and you can't at times, until I started treatment, when things rapidly improved after just 2 weeks on the first treatment. And before that, I couldn't walk down to the village in one go. I had to stop several times. I mean, I literally had the body of a 90-year-old. But anyway, started on treatment. They identified I was ALK positive, and then things really started to look up. Was told, could have several years, good years. The treatment was so much better than chemo. I wasn't looking at chemo, so that was a godsend. So there was a period of, this is good. You get used to the side effects because all the treatments come with them, and sometimes they get you down, sometimes they don't. I think one of the hardest things is side effects never go completely, so they wax and wane. And one of the hard side effects at the moment for the treatment I'm on is fatigue, and you just feel washed out and just don't want to do anything, and there's days when you just think, I'd love to feel like I did for one day before I had cancer. I could get so much done. It would be lovely. But it's not to be. I'm living a great life. I mean, I am living with cancer. I'm not dying of it at the moment. So I've done loads of things, been traveling since I've been diagnosed. But yeah, you have good days and you have bad days. As much as you try, you realize your old life has gone. So, there's an element of mourning that, and getting used to your new life, and what does that look like, and trying to find a new purpose, because I finished work, and so it was important to me to have a new purpose, because I kind of lost my identity. It's like, so what? I'm just a cancer patient now, and I found that hard at the beginning as well. So then decided to set up a support group for other ALK patients in the UK, and that's given me a real purpose. So I love the work. Sometimes I find it a bit much, I'll be honest. I wish I'd never started it, but I don't really. The friends I've made, ALK friends from across the UK as a result, are amazing, and count them as friends already within a very short period of time. So yeah, so there's good days and bad days, mostly good. It gets slightly easier as it goes further along, although scans sometimes get harder because when you're on a treatment, you know it's not going to last forever. So I've been on this current treatment 3.5 years. So every scan now, you think, well, it's going to stop working now, isn't it? This will be the one. This will be the scan. So at the beginning of my diagnosis, I thought scans would get easier over time, and you would just treat them as something, you know, in the diary, nothing to worry about. But actually they can cause more anxiety than less the longer you go on. And you learn these things as you go along. You don't realize at the time. But overall, living the high life. COVID has stopped a lot of that, which is a shame, because while I was going out with girlfriends, we were off out visiting places, going on holidays, and all that's come to an end. So really hoping that this situation isn't going to last forever, so that I can pick things back up again and carry on.
Well, words are really failing me right now, because that is 3 really, very powerful videos. And I'd just like to thank everybody for taking part in that, for Meryl, for Deborah, and for Gunther. We should never underestimate how hard it can be to share such personal experiences and how you feel, because we all try to protect ourselves and our emotions and our families. So I would just really like to really thank them on behalf of all of us for sharing that. Really very, very powerful. Sorry, now I'll pass over to my fellow board member, Lavinia McGee, who is going to moderate our question and answer session. So if you do have any questions, please do pop them in the chat box, and we'll hope to be able to answer a couple of those. Over to you, Lavinia.
Thank you very much, Anne-Marie. And again, thank you to all our speakers today, and especially to Deborah, Meryl, and Gunther. It was quite extraordinary. But I'll kick off the questions. The first one is from Shane, who's from Ireland. And he also says, hey guys, great discussion regarding cancer care, but any advice on how doctors can try and help reduce stigma for their patients? And I guess maybe this one's for you, Saba, to kick off with.
Yes, thank you so very much. I mean, the word for destigmatization, it's communication. So as you will going to find in the report, in the Lucha report, it's highly important to raise awareness among healthcare professionals about communication, because we know that good communication between a patient, a person affected by cancer, and healthcare professional is actually associated with lower levels of cancer stigma. We have data, especially for lung cancer stigma. So my background and my personal opinion is that most of the doctors are aware of this, psychosocial needs and communication needs that we all have. And let me say that for us, for me, as a son of a father who died of lung cancer, it's also very empowering to see all your stories and survivorship. So I think in this communication with the doctors, it's pretty important to start prioritizing these psychosocial needs, these psychological needs, and to talk not only about the disease, but also about the person affected by lung cancer. And on a more general level, I think that sharing your stories and sharing your survivorship, it's actually one of the best way we can communicate, because yes, it's touching, it's moving, but it's also really empowering.
No, thank you very much for that. I guess just another point relating to stigma again is, many other cancers have associations with lifestyle factors, but none have sort of that unfair stigma that's related to cancer, and how can we challenge it? from other cancers to lung cancer?
That's true. I mean, most of the cancers, I mean, like 40 or 50 years ago, we had the big C. And, this was the biggest stigma and burden you can get at that point. And in the meantime, because, of education and of, better means and better, training in healthcare professionals, the big C started to change. Well, it didn't disappear actually, because in some countries and in some places, the big C is still around. But unfortunately, the big C changed, and some of the cancers, like lung cancer, also in Romania, we have an issue with the cervical cancer, which is also very stigma sensitive. Things unfortunately didn't move, and stigma, it's one of the highest cancer distress experience that you can get when you have lung cancer. And that's especially true if have had or you have a smoking behavior. But as we all know, lung cancer, it's not just about smoking, and we should discuss that openly. So I would say that from a psychological perspective, the big C, it's still around with other names, and we should do more to raise the awareness of healthcare professionals, also of general public. But again, also we as psycho-oncologists, and I was so, happy because, in your survivorship sharing videos, I have seen and I have heard the need for more psycho-oncologists. Yes, but psycho-oncologists working with, persons affected by lung cancer should actually have interventions which are lowering the stigma, because stigma, it's, considered something invisible, but actually it's a form of cancer distress, which has absolutely the same effects as any kind of distress. It has an overall negative effect on communication, on decision making, and also on quality of life, and of course on the mood of the person, on the psychological well-being of the person affected by it. So stigma, it's not just a word, it's actually cancer distress, and it's a disguise of the big C, unfortunately, for those who are fighting this type of stigma-sensitive cancers.
Lovely. No, thank you very much for those thoughts and comments. And I'd just like to mention Michaela, who would like to very much share work with us. In October, did some research about the legislative initiatives across the EU in support of, in particular, carers, which very much is what our fifth report is about, looking at not only those affected by cancer, but their carers. So thank you very much for that, Michaela. That's very kind of you to offer that, and we'd love to see it. In the interest of time, I think that's all we've got for questions. I don't see any other comments coming through.
Lavinia, can I just ask Sean a quick question? Do you, and I'm sorry now, we've continued the train of stigma, but from your experience at the EU level, Sean, do you feel that the stigma associated with lung cancer is having a negative impact of getting a strong voice around lung health policies or lung cancer policies, such as lung cancer screening, implemented across Europe? Do you feel that that stigma is having an impact at EU level, or kind of what is your perspective on that?
I think it may have had in the past, but that is now changing. There is a determination in Europe that we have to try and defeat cancer in all aspects and in all forms. And it's now a priority for the European Union, particularly in this commissionership's mandate, to try and do so. And we have a big conference coming up in my own group, DPP, here in the new year, to discuss all these aspects and to see how we can progress it. But definitely, from listening to some of the witnesses there, I myself was surprised at the level of stigma that was there and how it affected the patients. And when you have somebody telling you, as you found out in your survey, that 70% regretted telling some people that they had cancer, that is an indictment in many respects of society, that should be the case, because you have expected that when they told people, and you wouldn't go around telling everybody, that it's a positive rather than a negative feeling they should get from it. So obviously that's something that we need to look at. And I will be bringing these points which I have learned here today and looking at your survey to those discussions when we have them in the new year on cancer. Because one of the great things about what you have done is that you have taken it away from the actual disease itself and looked at the societal and psychological and communicative aspects of it. And that's something maybe we haven't given enough thought to. And that certainly would help to highlight the stigma and the need to get rid of the stigma and how we actually do it. And that's something that we will be looking at, and I think we can do at European level.
Lovely.
Great.
Thank you very much, Sean, for those comments, and to everyone for your attention today. And I'll just hand back to Anne-Marie. Thank you.
Thank you so much, Lavinia. We are nearly now at the end of the launch of our report. And Tommy Bjork, one of my fellow board members, is going to now bring us the two main call to actions that have resulted from the report data. And then when Tommy has finished, the baton will come back to myself, and I'll say a few last words to close out the meeting. So over to you, Tommy. So I don't know, maybe we're having some technical difficulties there, maybe, Tommy, I'm not too sure.
Do you hear me now?
Yes, we can hear you now. Thank you so much, Tommy.
It's very easy to read our calls to action after listening to Meryl and Deborah as patients, and from even Dr. Sabo and Günther about caregivers, because I'm a patient myself. I'm cured now. I got my diagnosis 16 years ago, but I've been working for 12 years now with the patients' net toll-free calls. So I talk to every other fifth week. I talk to patients for a week and caregivers, and I can witness that caregivers are carrying a very heavy burden. And it's very, after listening to that and to these witnesses from the patients today, it's very easy to read these sentences. Provide integrated psychological social services in the lung cancer care pathway. Yeah, I can agree that we should improve quality of life for people impacted by lung cancer by delivering access to appropriate psychological and social services throughout their entire care pathways, tackle stigma through improved communication skills. I agree with every word that Dr. Saba said, because we have met very skillful doctors that help you with the technical side, but have no communication with the patient. And that's not, if you don't trust your doctor and don't feel that he wants to cure you, that's very bad. That's very bad. So I think the other part of the action, if you can chase the picture. Yeah, I can't read it now because it's something in the way, but I have to read it from just people. It's increase the awareness of patient organization and non-government organizations. And I think it's very good because I can see in the national work with lung cancer in Sweden that when doctors and nurses, especially nurses, are engaged and know about the patient advocates and can communicate and get contact ways to the patients to reach us in also advocates, because I think especially Meryl said in her witness earlier that it's just another lung cancer patients that know exactly how you feel, because so it's very essential for, I think we patient advocates have a great task in when it comes to stigma and to get psychological assist to patients and caregivers. I think that's very essential.
Thank you so much for that, Tommy. And I think those are two very strong call to actions with everything that we've heard here today. So I know we were tiny little bit over time, so hopefully you'll bear with me now until I say a few words just to close us out. So for me, really, it's about thanking everybody. Now, I really hope I do not miss anyone out from my list. And if I do, I sincerely apologize. But I would just like to thank everybody for attending today, for being part of this virtual launch. I'd like to thank all our supporters, all of our members for all the great contributions they've made, not only to this report, but to the work that Lucha does throughout the year. I'd like to thank Sean and Zaba for their talks at this meeting today. And it was really great to get their perspectives. I mean, I just honestly can't find the words to thank Meryl, Deborah, and Gunther for sharing their story. I mean, it is just a very privileged thing we find ourselves in when people open up and share their story, their journey with us. And I would just like to say a huge, huge heartfelt thanks to the three of you for doing that with us today. I would also like to give a special word of mention to the Lucha board who are here for putting up with me, I guess, and for helping to support me in my first term as president of the organization. You guys are amazing, and I'm so incredibly lucky to work with all of you. I would like to also give a special mention of thanks to Alfonso, who's been in the background, organizing everything, dealing with all the last minute technical issues, all of those things. So he's been in Mission HQ, helping us all to ensure everything moved smoothly. So Alfonso, thank you, thank you, thank you, thank you so much. I'd also like to say a huge special mention to Diego and Mas que Ideas. And I'm so sorry if I've mispronounced that, Diego. Without you and your foundation's support, we really couldn't do any of this without you. And I know it has taken a lot of time and it's been a complicated report to put together, but we really appreciate everything you do for us and the organization, and for your never-ending patience with us as well, I'd like to say. And with that, I'd like to bring this meeting to a close. Thank you all again. Let's all continue to work together as a community across Europe so that a person's socioeconomic status or their geographical location doesn't influence the outcome they have with this disease. There's a lot to be done, but by working together, we can really, really, really make a difference for people impacted by this disease. And with that, I'm going to pass to Alfonso, who's going to close out the meeting with a very short video clip of some of the issues that came from this report. And I'd also like to thank Bernard for being part of this next video that we're going to see. Thank you all so much. Stay well and stay safe.
Hello, my name's Deborah Montague and I was diagnosed with ALK-positive lung cancer 4 years ago.
Mein Name ist Günter Kranz. Ich lebe mit meiner Frau in Berlin. Meine Frau erhielt im Jahre 2007 gleichzeitig die Diagnosen Brustkrebs und Lungenkrebs.
Mi nombre es Bernard Gaspar, soy el presidente de la Asociación Española de Afectados de Cáncer de Pulmón y bueno, yo fruto de que a mi mujer le diagnosticaron un cáncer de pulmón, bueno, pues creamos esta asociación.
When I was first diagnosed, it was devastating. I didn't expect it. I was fit and healthy, as I felt, working full time, and so it was a massive blow.
Die Diagnose Lungenkrebs hat für mich persönlich ganz gravierende Folgen gehabt damals. Ich hatte Angst um das Leben meiner Frau. Ich konnte mich monatelang nicht konzentrieren.
El cáncer de mi mujer, ¿no? Dulce, bueno, pues impactó pues como a cualquier familia con hijos ya más pequeños. Nos dejó en estado de shock, sobre todo porque desconocíamos todo lo que era la enfermedad.
So you're still having maybe some scans and then you start in treatment, which means that you have to have blood tests every week to start with. So there's lots of hospital visits, which again was quite disconcerting because I'd never really been a patient before.
Weder bei der Diagnose noch nach den beiden Operationen an der Lunge. Und nach einer Chemotherapie hat uns jemand gesagt, dass es die Möglichkeit gibt, eine psychologische Hilfe in Anspruch zu nehmen. Bei der Rehabilitation ging es gut, darum kümmerte sich der Sozialdienst im Krankenhaus.
Y por supuesto, claro, impacta desde el punto de vista emocional, social, económico, laboral y nada, rompe totalmente todos nuestros proyectos de vida y tenemos que en ese momento reinventarnos, ¿no? E intentar cambiar o virar hacia otra hoja de ruta en nuestras vidas, pero que bueno, que teníamos que para ello bueno, pues tirar hacia adelante.
For me, I would like to see psychological support offered up front for every lung cancer patient that is diagnosed.
Als Selbsthilfeorganisation fordern wir, dass Onkopsychologen und Palliativmediziner in den Lungenkrebszentren von Anfang an in die Behandlung und Betreuung eingebunden werden.
Que faciliten y desarrollen un modelo asistencial que dé cobertura integral a todas las personas con cáncer de pulmón.